Hi, everybody, and welcome to the first Endometriosis Clarity Forum. My name is Chris Jackson. I'm the president and CEO of Cicero Diagnostics. We do the Receptiva test. For those of you who don't know about Receptiva, it's an endometriosis detection test which helps women that are experiencing pain symptoms that have gone undiagnosed. And it's also used in the world of fertility for unexplained infertility, failed IVF, as well as folks that maybe will never set foot in an IVF center but are having problems getting pregnant or staying pregnant. So tonight we're going to talk about endometriosis. And unlike a lot of different podcasts you might watch where they'll touch on endometriosis, this is going to be an ongoing series where we're bringing healthcare providers and patients to share their experience. As you listen to this, you're going to hear some things that will probably align with what you might be going through. And this is a great forum because we also give you the opportunity to ask questions and get real-time answers. And if we don't get to all the questions tonight out there from our audience, just know that we will respond in due time to make sure that everyone gets an answer to their question. I'm very excited about tonight's first episode because of the folks that we have on here are different journeys, whether it's on the healthcare side as a professional or the patient side. So I think you're going to find this very fascinating, and we're glad to have you with us. So tonight, our panelists that are going to be here and joining us in this conversation. First, I'd like to welcome Dr. Joy Brotherton. Dr. Brotherton is a MIG surgeon. If you don't know what MIG stands for, it's minimally invasive gynecology surgery. And I'll let Dr. Brotherton explain a little bit more about that. But she has over 15 years of experience in this field, trains other surgeons, and was one of the first people to be doing this minimally invasive type surgery that we'll get into tonight and talk about. Our two patient panelists, I'm excited to say, represent both sides of the coin in terms of endometriosis. So you think of what people know about endometriosis, and a lot of people think of the pain patients. And Denny Shea Martinez, who's joining us today, has got a story that no one rivals. I'll just tell you that. From the age of 15 on, trying to get answers for her situation. And Denny's going to share with us just about that venture and everything that she's been through. Our next guest is Hannah Sanders. She's an influencer, but she never thought she'd be influencing in this area of her life. But she is very candid. You can find her out there talking about what she's going through. She's going through experiences right now too. So this isn't something talking to you about what happened 2 years ago. It's happening right now for her. So welcome everybody. Just excited to have you here. And I think the best way to start this would be Dr. Brotherton, for the folks out there that think they know about endometriosis. We're all learning there's so much more about it that we don't know. But can you give us this 2-minute synopsis on what is endometriosis, how it happens, why is it targeting some women, and what's going on in detection, and how women typically find out about it a lot further down the line than maybe they should?
Yeah, well, first of all, Chris, I am not one of the first people who've done endometriosis surgery, but I did my fellowship 20 years ago, back when there were only 12 fellowships in the country, and we have over 50 now. So in the last 20 years, we've learned so much about this surgery, and as surgeons, we've gotten so much better. The surgeons that are graduating now are so well trained compared to when I trained. There's just so much more awareness about the disease. But essentially, endometriosis is when tissue that behaves like the lining of the uterus is found outside of the uterus. And so I always explain it as a chronic inflammatory disease. And it's chronic. It usually doesn't always go away. And so it can present in so many different ways. When I was in medical school, it was literally one paragraph in a book. But it affects so many different organ systems. So it can cause painful periods, pain with intercourse, pain with bowel movements, pain when you're not on your period. Um, it can mimic other diseases and you can get misdiagnosed over decades. IBS, you can just be told that you're a whiny woman, right? There's so many things that it could mimic because it can affect so many different organ systems. Now that I'm working in the fertility space, I am seeing so many more patients that have silent endometriosis, and their biggest presenting symptom is just trouble getting pregnant. And the more we learn about this disease, the more we're learning that there's other diseases that go along with it. So it seems to be like a systemic disease, higher incidence of things like allergies and migraines and depression and anxiety. It just really can affect a woman's entire health.
And statistically out there, I think everyone agrees it takes on average about 7 to 10 years for most women to get a proper diagnosis. And a lot of that turns out to be the healthcare provider that they're seeing, who they're first trying to vocalize this to, who, for the most part, normalizes a lot of the symptoms. And it really takes that patient to take that next step to say that. And that can be a challenge, I know, for women. If you're just going in for an annual and you've got 15 minutes maybe with your healthcare provider, it's not the time to be quiet. You really have to speak up. And I think that's part of the problem, is that some women are not ready to do that. And it's that next step, I think. And Denny, that's probably the best intro. Can you tell us your story? And I know it's long, but such an early age, you were already fighting this and trying to figure things out.
Yeah, I'll abbreviate it as best I possibly can. As you mentioned, at 15, I was having some pretty irregular, heavy, painful periods, which as an athlete did not work well. So early on, I needed that to be addressed because I still wanted to be an active teen. So I went to the doctor and they put me on birth control, and there really wasn't much conversation around, what could be causing that, just that this would help regulate my cycle so I could get on with my life. So, and at the time I didn't know to ask questions. Is with the 90s. I didn't research these things yet. So I just trusted what, the doctor offered to me, had medical management for 10 years, just for birth control, just for irregular, heavy, painful periods. After 10 years, I went off birth control. And from then, for about 10 years, so another decade's worth of time, my body started to slowly decline. I had the painful periods come back, the irregularity, the heaviness, and then the widespread pain started to happen. So these cyclical points where I would be experiencing, period pain, but also pain in my back, pain in my ribs, pain in my shoulders, pain in my neck, started to get worse and worse. And I did
So
everything I
some of
could. Yeah.
some of the specialists that you were seeing, or the doctors that you were seeing,
Yeah.
what were the early guesses? And and
Oh,
and besides putting you on birth control, just saying, let's normalize some symptoms here and take care of that.
right,
What
right.
kind of things were you getting, and the kind of specialists you were seeing?
Well, I would say I originally started with a naturopath because I felt like, oh, they'll have a gentler approach to medicine, because that's kind of where I was. So I did everything from allergy testing to stool testing. They did, and then I went the GI route first because I didn't really think it was a period thing. So I did colonoscopy, endoscopy. I remember starting to do my own research and considering like this might be endometriosis because this is aligning with all of my symptoms. And when I asked the doctor, the gastroenterologist, during her physical exam, I remember her laughing at me when I asked if it could maybe be bowel endometriosis. And she wasn't the only provider that treated me that way, which is really challenging when you're going in for something that's causing some chronic pain. By the time I got to my surgeon, I'd seen 19 doctors, all different types of specialists, so much imaging, so many out of pocket costs. 2022 is when I had my first surgery. It was life changing and necessary for my quality of life. And I went from having 3 good days a month to now having, 3 or 4 or 5 difficult days a month, but it's much more manageable now.
Very good. Hannah, other side of the coin, you're experiencing fertility issues. You've already had a child, and you have something we call secondary infertility, which is, hey, it was easy the first time. It's got to be easier the second time. Uh, Now we're talking about a different form of endometriosis where you weren't having all the type of classical symptoms that someone like Denny was going through. Did it just come out of left field to you that endometriosis could have been a potential issue?
Yeah, I would say I had some thoughts about it because it was taking me so long to get pregnant. I started doing research. Why could this be happening? I started wondering, could it be endometriosis? I just recently learned in the last like year or so that silent endometriosis exists. And I started asking my doctor. Um, but yeah, my only symptom was infertility.
Okay. Dr. Brotherton, both sides of the coin here. You see all of these patients. You have patients coming in that have had a long list of symptoms. Someone like Denny, who's had all these complications going on forever, different solutions thrown at her. And then you're also seeing fertility patients that are still in shock that they're there because they don't think they have a family history. They don't have any of the classic symptoms. Uh, Tell us a little bit more about your experience with both of those types of patients, and then just I guess touching on how diversified the symptoms are. One patient could have all of these classic symptoms that Denny has, and others can just I don't feel right, my periods aren't normal. It's all over the board. I think that's part of the problem with endometriosis detection. For the most part, is you just don't have four or five that are the steady norm. There are some classic ones, but I'm sure you've seen everything.
Yeah, I've had a very varied career, a very kind of lots of different things in my career, from working in a county hospital to a boutique fertility practice. I would say my rules in general are painful periods are not normal. So if you are not able to function and you are only having 3 good days a month, then that's not normal. Um, Number one. Number two, um, don't expect that you're going to get endometriosis addressed in a 15-minute annual exam. General OBG medicine is very broken. It is very broken on so many levels, but many general OBGYNs who are delivering babies don't have the time or the focus to dedicate to investigating what endometriosis is. So if your doctor is kind of brushing you off, most women have that intuition, right? You know your body, you know what's going on. If your doctor's not listening to you, we have trained so many people now through AAGL fellowships that really have a focus on endometriosis and that are dedicated to treating women with this disease, not just surgically, not just medically, but looking at alternative and adjunct therapies, because I think you have to attack it from sort of three sides: surgical, medical, somatic therapy, Danae. There's so many ways to attack it, nutrition. Um, so those are kind of my rules. My other rule is we want to limit the number of surgeries that you have in a lifetime. As a surgeon, it's disappointing. It happens to all of us. You operate on someone, they don't necessarily get better. You're not 100% cured. You still have a few days of bad days, right? So for me, kind of those are the extremes of pain. The other side of it is if you're having unexplained infertility, if it was easy to get pregnant the first time and they're telling you, oh, you have unexplained infertility. In my experience, it's never unexplained. There's always a reason. There can be a combination of reasons as we get older and our eggs get older, but it's usually never unexplained. And that's when we need to go looking for silent endometriosis. So, I think social media has been very helpful with bringing awareness to endometriosis because gastroenterologists, ER doctors, pediatricians, there's a lot of different kinds of doctors that are seeing patients with endometriosis symptoms. And again, it was a paragraph in medical school. They don't know what this disease is. So you have to advocate for yourself. And if you go online and you hear women talking about their experiences and it sounds like your experience, then seek out the people who are dedicated to treating this disease. The American Association of Gynecological Laparoscopists, we are graduating over 50 surgeons a year. They don't just do surgery, but they're very dedicated to focusing on this very complex disease. It's very complex. And I can't look at you and tell you you have it just by looking at you, right? It's a disease that is traditionally diagnosed by doing a laparoscopy, by putting a camera in your belly under general surgery, under general anesthesia, and looking for it. And in terms of how it presents in patients, I can tell you I've had patients who went to the ER every month because they were in such severe pain. And when I scoped them, I saw like two teeny tiny little dots of endometriosis, right? The amount of disease doesn't equate to the amount of pain. The other side of that is I've had patients who never complained of pain, and we go in to take out fibroids and they've just got stage 4 endometriosis everywhere, and they didn't ever really have pain. So it is very much a complex disease that requires time, and it requires someone who wants to treat you, who wants to focus on this and take the time. And more people are coming to the forefront and taking an interest in this disease. Um, because I think in general, women's health and endometriosis has been understudied and underfunded. And so you have to really find the people that are willing to take care of you.
Very good. Denny, you're a self-proclaimed introvert, but when it
I
comes to
am.
the topic of endometriosis and your journey, this other person in you has come out. And I know you've spent a lot of time through social media, through your webpage, educating folks out there, hopefully so they don't have to go through what you went through. And hopefully now a lot of the advancements have made a dent in that so that doesn't happen. But you're probably the supreme advocate. What advice would you give, Denny, for the women out there that they're not quite sure how to vocalize what they're going through? Because it's so important for them to speak up, or things can just get, pushed under the carpet for another year.
Yeah, absolutely. It really depends, I think, what you're willing to do as an advocate. So it could be something as simple as asking a friend to come to the appointment with you, or a family member. So that way you're not in there alone with a doctor or perhaps a new provider. And it's the, oh, awkward new doctor feeling. I hope they believe me. So having someone with you can be a really regulative force for your nervous system. So perhaps you're able to speak more clearly when, the doctor comes in. So, bringing a friend, doing your homework, as Dr. Joy mentioned, there are people that take a strong interest in this. So as much as you're going to get, they're getting to know you, but you also want to get to know them. You're sort of interviewing each other. Like, is this going to be a fit? Are we going to be able to work together in my care and managing, however this disease is unfolding in me? You are an expert, and there's so many things that you can track and get data now. So if you are using the fertility kits, if you're using different wearables to figure out your sleep and your HRV scores, I created a journal for myself because I like to write things, and mine has a body map. So I would doodle on my body chart. So for me, it was much more visual and I could get a quick look. I would take these in. I would take in all of my reporting. So when the doctor walk in with my folder, they knew I was serious. I've checked off a lot of boxes. I still don't have answers. Can you help me? And maybe it was a no, but I would always ask, do you know anybody that can? So I didn't always look at the opportunity like, oh, this didn't work out, but maybe they know someone or they can start to point me in the right direction.
So you mentioned the surgery was life-changing for you, and it made such a huge difference in your life and your lifestyle. Hannah, when you find out you're positive for the Receptiva DX test, which gave the first inclination, and again, it's a detection tool, it's not a diagnostic, only the surgery can confirm that. You're just trying to get pregnant. You're trying to have the next child. The idea of surgery I mean, tell us about the other option that was presented to you, because I would have to imagine from your standpoint, it's not the first thing you're doing is raising your hand saying, yeah, let's do surgery. I had no clue that this was even a possibility.
Yeah, surgery is definitely not the first thing I want to do. I'm open to it, but suppression with Lupron Depot was also presented to me, and that seemed a lot better than doing surgery. So I wanted to try that first. Also, on my results, I noticed there was some like statistics at the end, or the last page, and it said, I believe it's like if you test positive with Receptiva and you treat it with suppression, you have like correct me if I'm wrong, but an 81% chance of like positive pregnancy after treating it with suppression. So to me, that was like really positive, and that's why I chose to do suppression over surgery. I'm still open to surgery if if none of my next transfers work, but I was happy that suppression was an option.
Well, I thank you for the 80%, but it was a little bit lower than that in our original study, but it was about 60%. And laparoscopy and or the Lupron, very close in their effectiveness in that very first transfer after treatment. Dr. Brotherton, you obviously, these patients are in front of you. Some are coming from the fertility center that you're a part of. Others might be coming to you from another fertility center just referred to you because of your expertise. How do you guide them on the treatment options? How much of an influence do you have, or how much do you try to empower them to understand what their individual situation is?
It depends on so many things. It's hard to justify doing surgery when you have no pain and your goal is to get pregnant and not to treat something that you don't feel. I do a lot less surgery now than I used to in the fertility space because I see so many silent endometriosis people. There's a time to consider it. If there's large endometriomas and you have good embryos waiting, if there's a large disease burden, it's a conversation that you have to have with the patient. Um, Also, I would say where I am now, I don't have the endometriosis team that I used to have. You really need to be at a center where a place where you have not just a GYN surgeon, but a colorectal surgeon, a urologist. You have a whole team of people to treat endometriosis pain, pelvic floor therapists. Um, Radiologists that can help you understand the imaging. We're getting better and better at diagnosing endometriosis on ultrasound, which is in real time. So there's a big sort of division of our field that's looking at how we diagnose this disease. You need to have a pathologist. Nothing's worse than taking out disease that to me is absolutely endometriosis, and the pathologist says, no endometriosis seen. It's like a big topic we have on our surgeon Facebook groups, right? So it's a discussion with the patient, and you have to really make that decision individually for each patient. Surgery, I love surgery. It doesn't always work. Sometimes there's microscopic inflammation. So it really depends on the patient, where she is in her journey, what their goals are, and kind of individualizing everybody's approach, really.
Okay. Let's talk about detection. 10 years ago, it was, and I'm talking specifically about the fertility space. Laparoscopy 20, 25 years ago was part of the general workup,
Yeah.
and it became expensive. It's always been invasive, but they would find endometriosis all the time, in up to 40% of the women, and they would treat it right there, and then they would begin the IVF process. Less and less in the reproductive endocrinology community are doing surgery themselves, and it's just a matter of time management and the number of patients that they're seeing. Kind of help explain the bridge in how someone would end up at your office versus the Lupron. Is it all on symptoms, or obviously our test, the Receptiva DX test, helps detect with a high probability that a person has endometriosis, but the average patient that's showing up at your doorstep, um, it, are the physicians just they got their hands up? Yeah, go see them. I don't know what this test means, and uh, I'm just
I'm
curious
a
the
mi-
level of what you think of the referrals that you're getting, how educated it is, and are you getting the right people referred to you?
well, I kind of think of myself as an investigative reporter because patients come to us for infertility, and I take a really good history and physical. Some of the things that light up in my head, we have a decent egg count, or maybe a lower egg count, lower follicle count than expected for age in somebody. So lower follicle count or a lower AMH, which is I know is not supposed to be 100% diagnostic of anything, but I see a correlation. Someone who tells me I was put on birth control pills at a young age because I had painful periods, but they're fine. I just take some Motrin. It's not a big deal. Um, Somebody who used to miss work or school because they had painful periods. That my light bulb lights up. You probably have endometriosis. And when I present that to them, they want a baby, right? They don't care about anything other than the focus is having a baby. They don't want a big surgery. It's hard to get insurance companies to justify surgeries if you're not really having pain. I'm definitely guilty in my earlier years of my career of scoping people and telling them, you don't have endometriosis. I didn't see it, so you don't have it, right? Now we
Mhm.
have a much more systematic way over the past, again, 20 years where our society has really um, created systematic ways of doing surgery. So I think we're much better at diagnosing atypical lesions now laparoscopically. The one thing I will say is my other sort of rule of life is we want to limit the number of surgeries you have in a lifetime. I've seen women come to me, their poor bellies look like a roadmap. They will go to one doctor and does a scope and says, "Oh, you don't have it." They go to another doctor who maybe takes out a cyst, and by the time they get to an endometriosis specialist, it could be 10. I had one patient who had 20 surgeries in her lifetime. So more isn't always better. My recommendation is to, again, find a center that specializes in this. And if you're going to have surgery, really talk about it being the limited amount of surgeries in your, you don't want to go back every year having surgeries. I personally don't think that that's, always the best method. So when I have a patient who I suspect has endo and they go through an IVF cycle and they've spent all this time and money and emotional effort to make a precious embryo, and a lot of it's also age involved. So a lot of my patients are in their late 30s, early 40s, so they may not get a lot of embryos. And we want to give this embryo the best chance of implanting and giving us a positive pregnancy test. I talk to them about checking receptiva because if it's positive, we have a path forward to increase our chance of pregnancy. When I started in this fertility clinic 4 years ago, I was sort of like, how am I a MIG surgeon? I've never heard of this test. Most of my colleagues, most of my friends who are OBGYNs, they don't know about this test. It's really kind of been delegated to the REI practices. And I think it's a disservice because I think it could be very useful in a general practice. Why? Just getting that diagnosis could help triage you to the right person, or it could help you plan your life. We know that 30 to 50% of women with endometriosis may have trouble getting pregnant. So if you find out at 26 that you're receptiva positive and you suspected you had endometriosis, maybe that encourages you to freeze your eggs younger. Maybe it encourages you to do, if you're a teenager and you have terrible surgery, if we can catch that surgery surgically at a younger age, then by the time you have your surgery in 2020, it's not going to be so as advanced as what we think, right? So,
Mhm.
um, more information is always helpful. And I think, that's the job of receptiva diagnosis is to educate more physicians about this modality that can serve many purposes.
So let's talk about the treatment options because we have both of you that have experienced uh, different situations, surgery versus the hormone suppression. Uh, Obviously, Hannah, I think the hormone suppression is the most logical choice for someone, as Dr. Brotherton said, without symptoms. A little bit different though. It's not curing anything long term. It's suppressing everything long enough for you to get pregnant and stay pregnant. Dr. Brotherton, what advice would you give Hannah afterwards? I mean, she achieves the pregnancy and everything. Endometriosis is there and could affect her later on. Um, how can she follow up? Who should she follow up with? Because it's there. We know we didn't cure anything and take anything away. And in the case of Denny, surgery, the recurrence rates, depending on who did the surgery, are also a factor. And I think that's the biggest thing as women and everyone are learning about endometriosis is that it's very hard to have it go away forever. You do your best, but there's that chance of recurrence and you got to be watching. So do you advise them, here are symptoms that you should be looking for that would let you know, hey, maybe this isn't going to stay silent in Hannah's case or in Denny's case, hey, it's back.
Yeah, I mean, it's an interesting question. Do you treat a disease that's not bothering you, right? Hannah's biggest, issue is that she wants a baby, right? And this is inhibiting her. I'm a big fan, although I love to be in the OR, although I think medication can be very helpful for some patients, I'm a big fan of things like an anti-inflammatory diet, just knowing your body and just knowing that, because endometriosis is related to so many other things, I, I can't tell you how many of my patients with endometriosis, they're like, oh no, I don't have that, but they have depression and anxiety and they're on, antidepressants and anti-anxiety medications. There's a correlation, so do you have to treat it? Maybe she would be a good candidate for a levonorgestrel IUD after she's done having her babies to make periods lighter and potentially less dysmenorrhea, which is a painful period. It doesn't treat endometriosis, but we think can help with the symptoms. It's part of a conversation to have with her doctor, depending if any symptoms come up. If you think that you have IBS, I have so many patients, I have IBS. I don't think you have IBS. I think you might have endometriosis, right? So sometimes it's just as simple things as a wellness practice and an anti-inflammatory diet. Anecdotally, I follow social media. There's a lot of people that are starting to use things like GLP-1s for their endobelly symptoms. I think it's very interesting. We don't have data on it, but because medicine is not offering the answers, women are trying things on their own, right?
Well, so but
Ultimately,
in Denny's case, recurrence rates after surgery, obviously she had the corrective treatment surgery versus the hormone suppression, which just masks everything. But in Denny's case, someone comes out of surgery, what do you tell them about the chances of it returning? And
the statistics, kind of the studies, what they say are 20% of women will have recurrence of symptoms at 2 years and 50% at 5 years. So that makes us feel really bad about ourselves as surgeons. So I'm a big proponent of if you're going to have surgery, then you need to try to get pregnant right away, or you should also consider combining that with suppressive therapy, some type of hormonal therapy, or at minimum, really working on that kind of anti-inflammatory diet, lifestyle, things like that. But the data seems to suggest that pairing surgery with medicine may give you a longer interval. So it's worth that discussion with your doctor.
okay. Uh, so this is where I get quiet, and I'm going to let you guys both Denny and Hannah ask anything you might want to ask Dr. Brotherton. But one of the questions that came in, and this is somebody from England actually, and I apologize for them having to stay up so late, but talking with their doctor wants to do the surgery. They're not MIG trained. Uh, how do you get out of that conversation when you say, I think I want somebody that has a little bit more training than you? Because there are doctors out there that say, oh, that's okay. I do laparoscopy all the time. That's a tough conversation for a woman to have when they're saying, I really want to get this done right without hurting your feelings here, doctor. But any suggestions on how they should approach that?
Well, I don't think that every talented surgeon did a fellowship. Like I said, there was only 12 in the country when I did mine. So the people that came before me were really our pioneers of laparoscopic surgery, the people who taught me. They didn't do a fellowship, they created the fellowship. So questions to ask would be, what's your volume? How many of these surgeries have you done? What is our plan after surgery? What are you planning to do? Um, you know, there's so many different things that you can do during a GYN surgery. If there's bowel involvement, are you going to close me up and then tell me to go see a colorectal surgeon, or will you going to have a colorectal surgeon on standby to be there to do it all at one time, right? Do you have a urologist that you work with? Like, do you have a team? And for me, having that team available is really what can limit the number of surgeries you have in a lifetime and get the best sort of bang for your buck if you're going the surgery route.
And minimally invasive surgery, when someone hears that, a lot of women, and they'll just say, "Oh, that means it's less scarring." There's so much more to it than just less scarring, and as far as incisions and everything. How would you best describe MIG surgery and what the capabilities are over
Yeah.
traditional laparoscopy?
Well, it is laparoscopy, or it's either using a robot or a straight stick laparoscope. And what basically you're filling the belly up with CO2 gas and inflating the abdomen. And with a camera, you're really able to move the camera into the little nooks and crannies of the pelvis to explore it. If we do open surgery, we're looking down into the pelvis, but you can't always see areas where endometriosis hides. It likes to hide behind the uterus on the uterosacral ligaments. It likes to hide underneath the ovary. So having a camera in someone's belly avoids a big incision, so that's less pain, quicker recovery time. But it really allows the surgeon to really kind of systematically go through and look at all the different quadrants of the abdomen. More and more GYN surgeons are getting better at diagnosing and removing endometriosis from the diaphragm. So having that shoulder pain and um, not understanding why your shoulder hurts on your period, endometriosis can sit on the diaphragm. And so those are really advanced centers where endometriosis surgeons are pairing with cardiothoracic surgeons to remove endometriosis from the diaphragm, which if you do that wrong, I mean, you're looking at the lungs, right? So these are very intricate surgeries. They require a big team. And then you need a plan after surgery. What are we going to do to keep this chronic disease at bay? And if you don't want to go on medication, that's okay, but you have to understand, it can come back. It can come back with medication as well, but having that sort of long-term plan in place and also having a fertility plan, because we know as you get older with endometriosis, you can have a harder time. Not everybody, but 30 to 50% of women can have a harder time getting pregnant. So if you haven't had children and that's something that you want to do, and you've got a lot of endometriosis on the ovaries and you've got big endometriomas, what we do know that the literature shows is it doesn't matter how good your surgeon is, we're probably going to affect your egg count, right? So when you remove an endometrioma from the ovaries are very vascular organs. And so a lot of times they bleed. And so people will cauterize them. We know suturing them probably decreases the risk of hurting our egg count, right? Or using hemostatic agents. So there's things that we can do to sort of minimize the damage to the ovaries. But whenever you take a cyst out of the ovaries, there's a very high chance that you're going to decrease a woman's antral follicle count, which is the number of eggs that she has any given month in her ovary. I've seen 32-year-old women come to us who've had a cystectomy for an endometriosis cyst and endometrioma, and they've got one or two follicles on their ovary where they should, their other side has like 10 or 12. And so really talking about your fertility journey, what your goals are, does it make sense? And a lot of times it does make sense to get your eggs and make embryos before you do an aggressive surgery on an ovary? So these are all questions that you're not going to get answered in a 15-minute appointment with your general OBGYN who's doing your pap smear. This is where advocating for yourself is super important.
Very good. Denny, any questions you'd like to ask Dr. Brotherton?
Yes, when are you coming back to my neck of the woods? Um, More of like a general question. So I've found it very difficult to find someone to continue to support my care, post-surgery because my specialist is a surgical specialist. That's what
Yeah.
she does every day. And I love her for that. And I would never ask her to do this other side of it. But it seems like there's a lack of connection there, right? Like you're saying you're done with surgery. Maybe you're doing your own, anti-inflammatory, wellness regime, trying to keep your nervous system regulated and inflammation quiet. But are you looking to, like someone like me, I had diaphragmatic endometriosis removed. So I had stage 4. I'm going to need continuous care. I have a GYN and a functional medicine doctor, and I'm trying to make the two of them be like a specialist of endometriosis. So do you have a suggestion on who would be great for treatment if you're not able to see like your surgical specialist as a continued doctor?
Yeah, it's definitely a hole in endometriosis care, having a comprehensive center. Yeah, I think a lot of us dream of that for the future, where you have maybe a mid-level provider like a nurse practitioner or a PA. At one of the offices that I work at, we have a acupuncturist, and they're great at helping with that adjunctive therapy. Right now, it's a lot of patients piecemealing their care together, and we don't have these great centers of comprehensive care, which is frustrating. Um, it's frustrating, and I think
Says a lot about the disease in general, everything that has gone
yeah,
on with it. Yeah.
so much of it has been patient driven though, and with social media and advocates like you guys, um, I hope that systems will see the value in caring for women for the future to build these centers. One thing that we haven't talked about, Chris, is women with endometriosis. There's a significant economic impact, missing work. There's an educational impact. If you're missing classes in college a week out of the month, it's going to affect your academic performance. Women in the workplace, there's a huge financial burden of this disease. And,
Hmm.
I think those of us who are endometriosis advocates and my colleagues, and every year we have our big world conference, AAGL, and there's several other endometriosis societies that are really working on more comprehensive care. But yes, surgeons tend to be just surgeons, and everybody kind of works in these silos, and it's very frustrating. And I think we were talking a little bit earlier before we went on air about how gynecological surgery is the lowest paid specialty of all surgeries. So we used to be a very competitive fellowship, and last year I think was the first year where the fellowship spots went unmatched because people coming out of residency see that, oh, you do these extra years of training and you're making less money than a general OBGYN, and they have these massive student loans. So we've got a lot of challenges in medicine. Um, a lot of people talk about medical influencers, and they poo-poo the information that they're being given online because it's not evidence-based. And as doctors and surgeons, we always want to use evidence-based medicine, but a lot of stuff is patient-driven, right? So
Yeah.
people advocating and talking for what worked for them. I I found out about somatic therapy through social media, and it's been a game changer for some of my patients. And I've used it myself and found it to be very, very helpful. The body keeps the score. And so if you are in constant pain, if you have that anxiety of like, oh God, my period's coming next week, and I just am anticipating how much pain I'm going to be in, it affects all parts of your body. And so I don't have a good answer. I don't have a good answer. I wish I did. I think this is the challenge of our specialty moving forward, that we need to create more comprehensive centers so that women can have one-stop shopping that by
I think
providers.
that's an eloquent explanation of where we're at with endometriosis right now, not only in detection and diagnosis, but how are we helping the patient before and after any treatment options. Hannah, we're short on time here, but I definitely want to give you a chance to talk about you're in the moment right now. You are finishing up Lupron treatments. You're not shy about sharing that on the web and the social media. I praise you for that. It's good for other people to see that they're not alone. I think that's the biggest challenge, Denny. I know you faced over the years is that you think you're alone in this, and you see the number of groups out there, and then you see someone like Hannah, who, like I said before, was an influencer, but this was not going to be necessarily what she had thought she was going to be influencing on. But Hannah, real quickly, your situation, where are you at? And any questions for Dr. Brotherton as you get ready for that next transfer after the treatment's completed?
Yeah, I have my third frozen embryo transfer coming up on Tuesday of next week, and it's the first transfer after doing Lupron suppression. So I'm hoping that this one has a better chance than the other ones. But I do have a question for you. I had an ovarian cyst rupture back in 2019, and my mom also had, this might be a two-in-one question. My mom also had an ovarian cyst removed by surgery when she was like, she was in her 30s. You mentioned removing endometriomas from the ovaries. Can an ovarian cyst be a sign of endometriosis? Because no one's ever told me that, but just hearing what you just said about removing them from the ovaries made me wonder that.
So there's different types of ovarian cysts, right? So I have like I would say not a million, but many, many, many times in my life, I've had patients come in from the ER, I had a cyst rupture. Well, it's the job of your ovary every month to make a cyst, which is the dominant follicle. It's about the size of a golf ball filled with water, fluid, clear fluid that has the egg inside. And when that ruptures, that's when you ovulate, it releases an egg. A lot of women will feel that pain and they'll go to the ER. And again, ER doesn't, I wouldn't say all ERs, but many ERs are not focused on women's health, right? So they say, oh, you had a cyst that ruptured, right? If you went back in time and looked at it, it's probably about 14 days into your cycle when you ovulated. That's a normal type of cyst rupture, right? There's other types of cysts. Cysts can be filled with blood that are called hemorrhagic cysts. And if those rupture, sometimes they can keep bleeding and cause internal bleeding. And that requires an emergency surgery to take all the blood out of your belly and stop that bleeding. There's types of cysts that have solid components in them called dermoids that can have teeth and hair, and they're super gross but really satisfying to remove. Those will not go away on their own. And endometriomas will not go away on their own. So if you had a clear cyst that ruptured, that doesn't mean it was endometriosis because there's lots of different types of cysts. But endometriosis cysts are very pathognomonic. They're often called chocolate cysts because when you rupture them, the fluid that comes out is hemolyzed blood that actually looks like chocolate. And those cysts don't go away on their own. And sometimes they cause pain, really bad pain, but sometimes people have them and they don't know that they have them. So in the fertility world, more and more, if people have small endometriomas, we will stimulate their ovaries and get those eggs before they have surgery on it because we know that we can potentially damage the ovary when we dig those cysts out of the ovaries. So lots of different types of cysts that you can have. Doesn't always mean endometriosis, though.
Okay.
So this concludes our first episode, and I'm excited because the whole idea of this was to set up endometriosis overall and just touch on. And Denny, I know I'll have you back and we can spend a whole episode with everything you've gone through and just the pain side for the pain patients. And Hannah, you're an ongoing story. So obviously we want to stay in touch with everything that's going on there. Dr. Brotherton, I can't thank you enough. I know you are a warrior in a fight where everything says I could have done something else in my life, and you've made this a calling. And it's folks like you that just bring this to light and keep a spotlight on it. And that's what we're trying to do at ReceptivityX as well, by offering a detection test that can help get the right people to the right specialists like yourself. But I'd like to thank all of you here. A special shout out. We had 4 or 5 guys sign up for this, and I know they're doing it because they're there to support their partner. And so that's a big deal for us too when we see the men joining that. And Hannah, I saw your husband firsthand on your videos and everything supporting. And it takes a village, but it takes an incredible partner. Everything that we talked about, not only the physical part of it, but the emotional part of it, the financial part of it, the stress on the marriage and everything. So we'll continue to talk. I'd love to have all of you back. Thank you for your time, for out there joining us on Instagram and Facebook. Just thank you so much. And we look forward to bringing you more of this content. Thank you, everybody.
Thank you.
Thanks.